Good morning, everyone. Um, I'm happy that we finally got a chance to talk about early onset scoliosis. This is really a overall uh, conceptual, and it's not really giving you the details of treatment of EOS, but just thoughts about the history and how the evolution has been over the past 15, 20 years. So I'll start. Uh, this is my um, uh, disclosures, and I just wanted to thank a lot of people who have taken uh, their, their help and are contributed to this presentation. I firmly believe that in any field, we have to be familiar with its past to be really competent in helping its in the future progress, and that's always true in any field. Deformity is basically uh, uh, three by age is about three categories, and adults and AIS has been the focus of spinal deformity from beginning, and the Scoliosis Research Society was formed the basis of dealing with AIS, and really that occupied the discussions and the research and education for many years. The adult and aging spine sort of added to it in late 70s and gradually um, got more popular to the point where if you look at the um, program of SRS, there's a lot of adult deformity in the program. Early onset scoliosis was basically uh, a stepchild and really didn't have any attention for years until more recently. And if you look at the result of reviewing the podium presentation of SRS, looked at the all there at the SRS website. You can go there from 1966 to 2021, but IMAS from 2009, there were 8,215 podium presentations. And we looked at the keyword uh, to look at the papers with early onset scoliosis, and only about 4%, it's 334, was dealing one way or the other with early onset scoliosis. And when you look at uh, the years, for about 40 some years, really not much was presented. Only past, last last 15 to 18 years was the amount of increase in the number of presentations and research in early onset scoliosis. And that really coincided with the establishment of ICIOS, where we are just focusing on early onset scoliosis. So it was all in the recent years. When you look at the type of presentation, type of topics, there were more on the diagnosis, or was not the diagnosis, but more on the treatment, because that was the area where we really didn't know what to do, um, and less on the uh, etiology and the diagnosis. So the reasons for EOS not having enough focus in the past has been many. Natural history and growth patterns are very complex. There is a significant variability in the diagnosis and etiology. There's no viable treatment methods available and no reliable outcomes resources for comparison of different types of treatment. And each center and each uh, uh, institution has probably a low number of cases to be able to get and learn from it. And obviously, there was no funding. The industry was not very fond in in investing in this field because of the very low number, and there were really others as well. So we really didn't know where we were, at that time. I think it's Sidney Burwell's saying that half of what we were going to teach was wrong and half was right. And the problem was we didn't know which half was which. This was a child who really raised my interest in early onset scoliosis, early 80s. And this child has a congenital scoliosis and thoracic insufficiency syndrome, and had several, what was available at that time, surgeries, non-operative and operative treatment. But with all of that, Patrick could not be saved. So it was really a question and what we know and what we should do about this issue. And all of the things was really not evidence-based, but mostly was opinion-based, based on the experience of each surgeon. So we went to the same thing. I informally surveyed friends, colleagues, experts to why EOS is different in terms of diagnosis, research, and clinical care. And I just sent emails to 40 people that I knew had more experience, and pretty good for a survey. Not informal survey, got 84% of 85% of response. And the responses to survey was basically in all categories, and you can see the division of that. The growth was the more uh, uh, response on that. So the major points was the growth and timing of intervention uh, was was different. So the patient is has clinical findings at 2 years, and then at 3 years the clinical finding changes, and you have to change the decision making about the type of intervention that you choose. Heterogeneity of population involved multi-systemic care, and that was the major point. Risk of mortality, there's no mortality sort of risk in the patient with AIS, but there is significant with EOS. Uh, and as you have seen, or as you know about the old research, was at the age of 40 or so, the mortality rate is twice in EOS, at least in the, if you look at the natural history. The outcome was complex, and really there was no outcome to measure the different methods of treatment. But there was also the finer points, but that's just as important. Small population, limited funding, require really advocacy for these patients. Family burden is just not the patient, but the whole family is involved. Impact of type of timing of the treatment is really high on families and the patient, and social and psychological need. And we have to follow these patients for a long time to really know how the treatment is effective. So one of the responses was Colin Noddy, that I thought it was the best, and said the EOS is real game stopper. A bad call means spending the rest of your life playing catch up with both surgeon and patient in the losing side. I mean, this is really tells the story of the early onset scoliosis. But looking a little bit positive, for the future, we are seeing more focus on EOS, growing spine, and understanding the pulmonary issues. There's increased interest, basically in the past 15, 20 years, multiple symposia, SRS and POSNA have had started actually in early 2000 here in San Diego. Um, Growing Spine Committee, we started that at SRS at about the same time. The ICIOS was established in 2007 in Spain. and now his 16th year was this year. So that really brought a lot of focus and research in the area of EOS. There was this increased, as you saw, uh, uh, in peer-reviewed publications, many presentations. The textbook of growing spine was just published a few months ago. That is now in the third edition, with about 140 contributors, and some of them are in this call. Uh, but the important thing wasn't industry driven. It is sort of the challenges that surgeons and the need and unmet need really brought this with the people who were interested in. For instance, thoracic insufficiency syndrome is something that Bob Campbell sort of coined, and really told us that really we are not looking at the spine. We should look at the entire patient. It's a disease that is, one of the features are spine scoliosis. And Greg Redding has really contributed more in the area of pulmonary function. The study groups that we had, the growing spine study group and children's spine study group, have joined the past 2-3 years, and pediatric spine study group has really now over 11,000 cases in the database, the largest database in the world as far as spinal deformity is concerned, with 186. This is like last, 6 months ago, surgeons involved in 12 countries. That has really helped. The ICUS is now 16 year, and it is really the focus and the center of research for scoliosis, early onset scoliosis. And we had about more than 600 research abstracts and hundreds of podium presentations and workshops in that meeting. It's much more than the SRS. The ICUS, that's the first faculty of the first meeting in Madrid, and this is in 16th meeting in Rome. Advocacy has been really helpful, training the FDA in the devices for pediatric use, and that has helped the approval of the devices at the national level. Classification has been helpful, but it's not really a ideal classification. Like etiology, we have neuromuscular cases where there is a combination of, for instance, muscle disease and spastic patients. They're all categorized in one category. But at least as the first step to make sure that we are talking sort of the same language, and the research is based on some understanding of the etiology of the disease, which is very important. So when we look at the evolution of the approach to EOS, we've been looking at the etiology, classification, variability. We really try to understand the natural history with different etiologies and different underlying diseases. Um, Pulmonary evaluation has been very important. Has been trying to develop methods of measuring and comparing that in these small children, which is not very easy and is challenging. And the treatments are different. The techniques are evolving. In each year or two, there's new device or new technique has been introduced, and the whole thing also is important when to start the treatment, when to stop the treatment. Complications, and obviously, is more, and we know that is a issue that we always dealing with, try to reduce the complications, and we still a lot to learn from it, from the data that's been producing. Outcome, uh, very, very much is the focus of evolution of developing some outcomes, but for EOS patients that we're able to evaluate whether we are winning or we are losing. And the definition is always changing. Even the changing of the age of EOS based on chronological age was from 3 years to 5 years, and then we get the 10 years, and now it's probably going back to different age group, because the upper age of EOS is probably can be combined with the lower age of AIS, and the tweeners, for instance, are uh, you know, getting out as a different category. So that's all evolving. So any of these factors continue to evolve, and so we're not really quite sure where we exactly are now either. Um, I think I came up with an article of Mike Glotzbecker that really talking about the evolution, and it, it is uh, another survey. So it's really, it's still on the era of opinion. He, surveyed 59 surgeons in the 44 more than 10 years experience, and again came up with the US uh, having the incredible diversity, and we have a diverse arsenal of non-operative and operative treatment for treating this population. And just brings the Claire Cook's saying that if Plan A doesn't work, the alphabet has 25 more letters, and in Japan it's like 204. So we have a toolbox of all kind of treatment that's been evolving and is increasing every year. CAS, Brace, Reptor, Lukey, Sheila, TGR, MCGR, and it's just coming, and then that's probably one or two more since I made this slide. I think his survey showed that the biggest setback in EOS is the impact, implant design, which I think is it just comes from us having not much understanding of how the natural history and behavior of these diseases with different etiologies are. Uh, the failure of eliminate complication is the biggest one, and obviously lack of understanding of the outcomes. The biggest unanswered questions, again, applies on complications, understanding the outcome measures, so we can at least know where the success is and where the failure is, design a better implant, how to handle very early severe EOS. So the common questions in EOS now is what is the normal spinal growth? We're still struggling with estimating and anticipating growth in different patients, and each patient may be different. Not only the etiology, but within the etiology could be different. That is the issue we have with tether, for instance, really being able to predict the exact growth in exact time. Are we improving lung function? We don't know whether the lung function is really changing the natural history. Um, are we uh, are we improving the quality of life? I think that's the ultimate goal. But whatever we do now, is it changing the quality of life? And uh, so how they relate to quality of life. So there is a lot of outside of the box implant innovations for EOS, and you can go through this list and look at the curve uh, actuator for MCGR, hydraulic implants, self-propelling, propagating the growing gods are all through this list. And and I think those are thoughts and sort of innovations, but none has been really a uh, true response or true answer to the question of that we're dealing with. Outside of the box, for non-implant issues, the magnetic signaling of the vertebral growth plates, biologic and growth plate injections to induce or inhibit growth. Those are some of the thoughts. Vascular stimulation, radio frequency to influence growth plate, and gene therapy, which I think eventually could be a evolution in the understanding of natural history and even the treatment of EOS. Genetic studies, therefore, has been slow a little bit in EOS, a little bit more in AIS. I think identification molecular etiology is very important, and the studies of AIS could help the EOS. And um, uh, Nan Wu, who's one of the surgeons now in Beijing in China, has really done some, and the only, probably two studies that is done in EOS. And he has found that sequencing enabled the molecular diagnosis, and even in 20% of these patients, including some that previously undetected, was able to identify the, the diagnosis and be able to help not only the child, but also the family. So because of that, we created a research interest group, and we call it RIG at PSSG, about etiology, and now collecting samples from at least two sites in TSRH, as well as Denver and then Australia, to study the uh, uh, the EOS genetically, and they're moving forward to proceed with that. And that's really a hope that maybe in the next 10 or 20 years would answer some of the questions. So the summary for the future is current evolution and progress will move forward. So will likely remain as dreams for some time. Technology will improve implants, as far as the properties, techniques, maybe less invasive. US patients are diverse and need diverse solutions. That's why we have this toolbox that probably remains for a while, as different techniques and different approaches to different etiologies and different patients within the etiology. Understanding the biology and genetics of each individual patient disease process is the key. And that's where the AI and all the new thoughts on precision medicine is going to work. Most likely, some of the answers in EOS. And then obviously we need some proper outcome measures to evaluate success or failure in our intervention. So there are directions we think it will be helpful to explore. And if we look at the uh, you know, paradigm shift, we're really going from what and how to who, when, and why. And that's really the different thought process of what we had in the past. Um, the proactive approach would be a better understanding of individual patients' disease process, what is really causing it, what is their predicted growth, natural history of the curve over time, and what's the right outcome measures to define our success or failure and capture their patient's functional outcome and quality of life. And there's always we have to be mindful of global impact. In most of the world, resources, education, healthcare, and so on is inadequate. I think we need to, I mean, this is also true in the United States, but we need to encourage systems where children with EOS are treated by providers in specialized environment and with enough experience. And that's what the probably the main area of focus of the GSO and the travels around the world. Probably Greg can tell you that the most difficult and issues that all the surgeons are dealing with are EOS, and a lot of adult surgeons are really not familiar with it. So that's what we need to be mindful. So this may be true. We didn't know where we were, and we don't know where we are, and we just have some ideas and directions that we think that we should be going. But I think it's a bright future for EOS because of the commitment and passion of those of us who care for children with EOS and the supporters. I think that's become very evident that when you go to, those who have attended ICIOS, the people attend there are really passionate about what they're doing. And no meetings I've been that faculties are pays for himself and they come in and there's really no expectation. So the compassionate quality care will be provided. I think we will strive to maximize outcomes and improving the quality of life, and we'll be intellectually stimulated every day by our interactions, our meetings, our research, and we learn from setbacks and use them for moving forward and continually challenge ourselves, innovate, advance our understanding and treatment of children with EOS and growing spine. And I'd like to thank you and just tell you that the next ICIOS is in Charleston, in South Carolina, in November 8 to 10. Thank you, and if you have any questions, I'd be happy to hear.
That was awesome, Dr. A. Thanks for taking us on that journey. There's so many incredible lessons that you just gave us in a very short period of time. What do you think of all this metal we're trying to use? Is metal the enemy? I kind of always think that whenever I do an early onset case, that I know it's a necessary evil, but I sometimes wonder if metal is the enemy of growing kids. How long is it going to be before we figure things out that don't use, metallic implants to address a much more difficult problem?
Yeah, I think that's correct. That we probably in a little child we prefer not to put any type of metal. We put hip nailing or doing some sort of a extremity and upper extremity and lower extremity work, and we try to remove them and try to something that will interfere with the growth. So it is the best we have as far as trying to correct the deformity, but maybe the best way would be not to put anything in the spine and try to correct it without any implant. I think the biology of different material and the reaction of the body to the different material is going to be the key. And at this point, the metal has the longest sort of uh, experience, or in children, has been there for years, that has been there.